Okay, everyone, let's get started. Today, we are going to talk about a really remarkable molecule in our body. It's the one that, well, it literally builds us from the ground up. I'm talking, of course, about growth hormone.
Namaste, students. Welcome, welcome. So today we are going to explore the body's master architect. Think about it. This is the hormone that dictates our height, our strength, our entire physique. It's an absolutely fascinating topic, so chalo, let's get started, shall we?
So, what's on the menu for today? First, we'll cover the basics of growth hormone. Then, we'll dig into its really cool double action mechanism. After that, we'll see how the body regulates it. Keeps it in check. Then, what happens when that balance goes haywire? And finally, we'll look at how pharmacology comes to the rescue. Simple enough, right? Right then, Section 1, the basics. Let's start from the very beginning. What is this growth hormone, and what does it actually do in our body? So at its heart, what is growth hormone? Well, it's basically a protein, a single-chain peptide hormone, to be very specific, made of 191 amino acids. And its main job, well, the name gives it away, doesn't it? Its main job is to make sure we grow properly during childhood and adolescence. It's the reason we reach our final adult height. But it's not just about getting taller. Oh no, GH has a whole range of functions. It's a builder, for sure. It grows our bones, our organs. It holds on to important stuff like nitrogen and calcium, and it tells our cells, hey, make more protein. But it's also a clever energy manager. It pushes the body to burn fat for fuel, which is great because it spares our carbohydrates. The only catch, this tends to raise blood glucose levels. And here's a very important point. Please note this. The growth of our brain and eyes, that's completely independent of GH. Very important to remember. Okay, so moving on. How does GH actually do all this magic? Well, it's not as simple as you might think. It's actually a really interesting two-part story. Let's get into it. Now, have a look at this diagram. It shows the whole pathway, the entire chain of command, really nicely. See? It starts up here in the brain, in the hypothalamus. The hypothalamus sends a signal to the pituitary gland. The pituitary then releases GH into the blood. And from there, GH travels all over, to the liver, to the bones, to fat cells, and it starts telling them what to do. So let's find out what those orders are. So the big question is, how does GH actually talk to the cells? It can't just walk in, right? So what it does is it rings a special doorbell on the outside of the cell. This doorbell is what we call a JAK stat receptor. And when GH rings that bell, bam! It kicks off a whole chain reaction inside the cell. This is what leads to all those changes in metabolism and even which genes get turned on or off. Now, this is where it gets really fascinating. You have to understand that GH has, well, it's like it has two different personalities. Its direct actions are very anti-insulin. It breaks down fat, it tells the liver to pump out more glucose, and it tells muscles, don't use that glucose. So what's the overall effect? It raises your blood sugar. But then there's its indirect action. GH goes to the liver and tells it to make another hormone, IGF-1, insulin-like growth factor 1. And guess what IGF-1 does? The complete opposite. It promotes growth, it helps make fat, and it tells muscles to take up glucose, so it lowers blood sugar. See? GH is playing both sides of the field. This dual action is a super important concept, so make sure you've got it. So with such powerful and kind of contradictory effects, you can imagine the body needs to keep this hormone on a very tight leash, right? So how does it do that? Let's talk about the body's really clever on and off switches for regulating growth hormone. It all works with a beautiful system called a feedback loop. The best way to think about it is like the thermostat in your AC. So, step 1, the hypothalamus shouts go by releasing a hormone called GHRH. Step 2, the pituitary hears this and releases GH. Step 3, GH goes to the liver and makes it produce IGF-1 and you get growth. And in step 4, once the levels of GH and IGF-1 get high enough, they send a signal back to the hypothalamus and pituitary saying, okay, that's enough, stop. This is what we call negative feedback. It's the body's way of keeping everything perfectly balanced. So let's zoom in on those switches in the hypothalamus. You've got the on switch, which is GHRH. Think of it as the accelerator pedal. It works by increasing a little messenger molecule called CAMP in the pituitary cells, telling them to go. Then you have the off switch, another hormone called somatostatin. And you guessed it, it's the brake pedal. It does the exact opposite. It decreases CAMP and tells the pituitary to slow down and stop secreting GH. An accelerator and a brake. Simple, but very effective. But what happens when this perfect little system breaks? When the accelerator gets stuck or the brakes fail? well, that's when things go wrong. And this brings us to the diseases, the pathological states that happen when you have too much or too little growth hormone. And this slide lays it all out very clearly. Let's look at the two sides of the coin. First, what if you have too little GH? That's hyposecretion. In a child, this causes pituitary dwarfism. They'll have short stature and low muscle mass. In an adult, it's not so common, but it can lead to things like weak muscles and bones, feeling tired all the time. Now, what about the other extreme? Too much GH, hypersecretion. The effects here are really dramatic. In a child, before their bone growth plates have closed, it leads to gigantism. They just keep growing and growing. But in an adult, after the bones are fused, you get a condition called acromegaly. The bones can't get longer, so they get thicker, leading to enlarged hands, feet, and facial features. All right, so now for our final section today. We've seen what can go wrong. The big question is, how do we fix it? How can we use medicines, pharmacology, to bring that delicate balance back? Okay, so for someone who doesn't have enough growth hormone, the main treatment is a drug called somatotropin. Now, what is somatotropin? It's simply human growth hormone that we make in a lab. We use something called recombinant DNA technology. Basically, we get bacteria to produce it for us. And the best part is it's absolutely identical to the GH our own body makes. It's the perfect replacement. And you'd be surprised how many things we use it for. Of course, there's pituitary dwarfism in children. That's the main one. But we also use it to help girls with Turner syndrome grow taller. It helps children who have chronic kidney problems. We can even use it for what's called idiopathic short stature, where we don't know the cause. And it's not just for kids. We use it for adults who are GH deficient, and even to fight that terrible muscle wasting you see in diseases like AIDS. It really is a powerful, powerful medicine. But wait a minute. What if a child has plenty of growth hormone, but their body just isn't listening to it? The doorbell is broken, you could say. In that case, giving them more GH is useless, right? It won't do a thing. So what we do is we bypass the GH step altogether. We give them the next hormone in the chain directly, and that drug is called mecasermin, which is just lab-made IGF-1. Okay, so we've talked about what to do when there's too little GH. What about when there's too much? For that, we need to hit the brakes, right? We need to inhibit its release. Now look at this chart here. See that category in the top left? Inhibit GH release? The main drugs here are somatostatin. That's our body's natural off switch, remember? And also man-made versions of it, which we call analogs. A common one is octreotide. These are the drugs we use to treat conditions like acromegaly. And that brings me to my final point today, a question I want to leave with all of you. We've seen that growth hormone is an incredible therapeutic tool. It can literally restore growth, it can rebuild bodies, but because it's so powerful, it's banned for use by athletes who want to get an edge. So this creates a really interesting ethical problem, doesn't it? As future doctors, where do you think we should draw the line between using this hormone as a therapy and using it as an enhancement? It's something for you all to think about. Thank you very much.
Welcome back, my dear students. Today we're going to tackle a really fascinating topic, the anterior pituitary. Array, you can think of it as the master gland of the body, the big boss. We'll be looking at the drugs that act on it. This is super important stuff for your clinicals, so let's get right into it.
Okay, so here's our game plan for today. First, we'll talk about growth hormone, then prolactin, two very important players. After that, we'll dive into the hormones of fertility. Then a quick look at TSH and ACTH, the controllers of other glands. And finally, we'll wrap it all up with a quick review of the must-know facts for your exams. Cello, let's begin.
So first on our list is growth hormone, or GH. I mean, the name says it all, right? It's essential for our growth. But what happens when the body produces just too much of it? Well, that leads to a condition called acromegaly. You start seeing abnormal growth, especially in the hands, feet, and face. It's a very serious issue, and we need to know how to manage it.
Now look at this. This chart shows us why our body's own hormone, somatostatin, isn't very useful as a drug. Look at its half-life, just 2 to 3 minutes. It's gone in a flash. That's where pharmacology comes to the rescue with octreotide. It's not only 40 times more potent, but it also sticks around for about 90 minutes. This huge difference makes it a fantastic drug for treating acromegaly and also for a very critical emergency, controlling bleeding from varices in the esophagus.
Of course, with every powerful drug, there can be side effects. Now, octreotide can give some patients tummy troubles, things like pain, nausea, and even fatty stools. And one more thing to watch out for, because it slows down bile flow, it can sometimes lead to the formation of gallstones. It's always a trade-off, you see. Now, this is really clever. We have another option that works in a totally different way. This drug is called pegvisomant. Instead of trying to reduce GH levels, it goes directly to the GH receptors on the cells and just blocks them. It's like putting a key in the lock that fits but won't turn. The hormone is there, but it simply can't do its job. It's a beautiful mechanism, and another great way to treat acromegaly.
Okay, moving on, let's shift our focus to the next hormone, prolactin. And you'll see a similar story here. When you have too much of it, a condition we call hyperprolactinemia, it causes its own unique set of problems that we as clinicians need to solve.
So, just think for a second. Why is having high prolactin a problem? We know its main job is to stimulate milk production in mothers after childbirth. So, what do you think happens when the levels are high at other times? You got it. All that extra prolactin basically messes up the whole reproductive hormone system. In women, it can cause milky discharge from the nipples, stop their periods, and lead to infertility. And it affects men too. It can cause a loss of libido, reduce fertility, and even cause impotence. So you can see it has significant effects on both. So how do we fix this? We use dopamine agonists, because dopamine naturally puts the brakes on prolactin. For years, bromocriptine was the standard. But now, have a look at the newer drug, cabergoline. It is so much better. It's more potent, and just look at that half-life, more than 60 hours. This means patients only need to take it twice a week, not every single day. And the best part, fewer side effects, especially nausea. It's a real game changer.
And this is a key takeaway point, something to highlight in your notes. For hyperprolactinemia, cabergoline is now the undisputed first-choice drug. It's simply more effective, so much more convenient for the patient, and much better tolerated. Easy choice, right?
All right, let's change tracks a bit. Now we're going to talk about the gonadotrophins, that's follicle-stimulating hormone, or FSH, and luteinizing hormone, LH. Think of these two as the directors of the reproductive system. They are absolutely crucial for fertility. As you can see here, FSH and LH have different jobs, but they work together as a perfect team. In females, FSH gets the egg follicle growing, and then LH is the one that triggers ovulation, the release of the egg. In males, FSH is vital for making sperm, and LH tells the testes to produce testosterone, a beautiful, coordinated dance.
So what controls FSH and LH? A hormone from the hypothalamus called GnRH. And this is where things get really interesting. The pituitary's response to GnRH is, well, it's a paradox. It's weird. If GnRH is released in short, rhythmic pulses, like a little drip, 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 the pituitary gets stimulated and releases FSH and LH. But if you give it a continuous, steady stream of GnRH, the pituitary gets overloaded and shuts down production completely. This strange behavior is the secret behind some very powerful therapies.
So let's see how we use that paradox to our advantage. With long-acting GnRH agonists like Leuprolide, we give a continuous dose. Now for a short time, you get a little surge of FSH and LH. But very quickly, the pituitary receptors just get tired of being constantly yelled at, and they shut down. The result? FSH and LH production stops. This effectively puts the reproductive system on pause, which is incredibly useful for treating conditions like prostate cancer or endometriosis.
Okay, moving right along. Take a look at this diagram. This is the complex process of making thyroid hormones in our body. And the signal that kicks this whole factory into gear, well, that comes from our next anterior pituitary hormone, TSH. We're almost there now. Just two more hormones to quickly cover, TSH and ACTH. These are the master controllers for two other very important glands in your body, the thyroid and the adrenal glands.
So TSH, or thyroid-stimulating hormone, is basically the on switch for your thyroid gland. It tells the thyroid to do everything it needs to do. Trap iodine from your diet, use that iodine to build the thyroid hormones T3 and T4, and then release them into the bloodstream. It's absolutely essential for regulating our metabolism.
And finally, we have ACTH. Now, this hormone's job is to kickstart the production of all steroid hormones in the adrenal glands. It does this by speeding up the very first and most crucial step in the whole process. Think of it like this. ACTH is the manager yelling, "Go, go, go," at the start of an assembly line. It gets the entire production of vital steroids like cortisol moving. Okay, everyone, time for a rapid-fire review. Pay close attention. These are the high-yield facts, the absolute must-know points from our session today. Ready?
First up, too much growth hormone. Think acromegaly. The drug you need to remember is octreotide. It's also used for bleeding varices. Got it?
Second, for high prolactin levels, what's our first choice? Yes, it's cabergoline. More effective, less frequent dosing, simple.
Third, for conditions like prostate cancer and endometriosis, we use that clever GnRH paradox with agonists like luprolide to shut down the system.
And lastly, for IVF, when we need to prevent a premature LH surge, we use GnRH antagonists like ganirelix. They act like an immediate off switch. So there you have it, a quick tour of the major drugs that act on the anterior pituitary. It's really amazing, isn't it? How understanding these complex feedback loops allows us to create such specific and powerful treatments. I want you to think about that GnRH paradox. It's such a counterintuitive but brilliant piece of pharmacology. All right, that's all for today. Thank you for your attention, and I'll see you in the next class.